Hi, everyone. Welcome to our last week of PSP. Just wanted to congratulate you all for making it through the semester and good luck for your exams. So today, Pranay and I are going to run through Phys, and then we have Jay and Meg running through their bits too, and then their bits are going to be added on to the end of our. So let's talk about regulation of MAP, mean arterial pressure, and the cardiac cycle. First off, what is mean arterial pressure? So last week we talked in week 11. Sayumi told us about how 2/3 of the blood that's pumped in the arteries will go towards pushing on the arterial wall. So this is why we have this equation. This equation is the mean arterial pressure, in words, is the average pressure in the arteries, and the equation is 1/3 of the systolic pressure plus 2/3 of the diastolic blood pressure. And this diagram explains that. What happens when there is a drop in mean arterial pressure? When there's a drop in pressure, we can observe something called orthostatic hypotension. So foot, stasis, standing, hypo, low tension. So that means when someone stands up, there's going to be a significant drop in their systolic blood pressure or diastolic pressure. What causes drops in mean arterial pressure? The primary reason is decreased venous return. If you can remember that venous return means the volume of blood that returns back into your right atrium, down through the system to be ejected from the left ventricle, then let's discuss 3 of the reasons why we'd have decreased venous return. So one of them is decreased end diastolic volume, which means low amount of blood that is in the ventricle before contraction. Then decreased stroke volume, low amount of blood that is pumped out in each contraction. And that also means decreased cardiac output, which is the volume of blood that is pumped out of the heart over a minute. And these definitions that I've just said are in the speaker notes for your reference. So this is the problem. Now let's talk about what our body does to fix it and then the solution. So the solution is we have these reflexes in our body called baroreceptor reflexes, also known as arterial reflexes, baroreflexes. And so it's a reflex that detects fluctuations in blood pressure and acts to increase and decrease the blood pressure accordingly. So let's learn about stretch-sensitive baroreceptors. So baroreceptors are stretch-sensitive nerve endings that detect and regulate blood pressure in systemic circulation via signaling to the autonomic nervous system. And they're located in the walls of the carotid sinus, the aortic arch, atrium, and vena cava. And the mechanism of action is here. So why is it stretch sensitive? You can imagine if there's higher blood pressure, the force of blood hitting against the arterial wall is greater, so the vessel wall will stretch. That's why these baroreceptors are responsive to the degree of the stretching of the arterial walls. So if there's low blood pressure, there's going to be less pressure on the walls, and the baroreceptors will notice this. As a result, it'll fire less firers, it will fire less frequently, and then that'll decrease the signaling of the baroreceptors to the brainstem. So that would be, here are the baroreceptors in the carotid sinus, and it will fire less to your brainstem, and then that will decrease parasympathetic stimulation and increase sympathetic innervation. And that results in vasoconstriction when the vessel has a smaller diameter. That will increase the pressure. And that also does other things to tell the body to increase heart rate, increase stroke volume, and increase blood pressure. So the main takeaway from this slide is when there's a low blood pressure, there's low firing. Don't confuse it with, oh, if there's low blood pressure, then the baroreceptors will want to activate more to send signals to the body to increase the heart rate, because it's the opposite of that. So low blood pressure and low firing frequency. On the other hand, increased blood pressure would increase the firing of baroreceptors to decrease the heart rate, blood pressure, and stroke volume. Okay, so what are 3 ways we can increase our MAP? 1 is increasing cardiac output, and 2 is increasing total peripheral pressure. And 3 is a combination of these 2. So you would want to increase the volume of blood to increase pressure, or if not that, then increase the pressure that is the force that is against the pressure of the blood in the vessels, which is TPR. So how do we do that? The words here are going to be the words here are for this diagram. So we activate the nerves that make our heartbeat faster and harder. This is the activation of the sympathetic nervous system, and it does 4 things: increase heart rate, venous return, total peripheral resistance, and increase stroke volume. And secondly, on the other hand, if it's not doing that, it would decrease the activation of the nerves that slow our heart down. And that would be decreasing the activation of parasympathetic nervous system. So here is activating what makes it go faster and deactivating what makes it go slower. Also, in the speaker notes, you'll also see I've added the equations. So MAP equals CO times TPR. To memorize this, mean arterial pressure, the pressure in the arteries, is equal to the cardiac output. That makes sense. And then the higher the total peripheral pressure, the resistance is, this should say resistance, by the way, total peripheral resistance. The higher the resistance it is, the higher the pressure it's going to be. So that's how we memorize that. And the second equation is cardiac output equals stroke volume times heart rate. This is a lot easier to memorize because stroke volume is volume per contraction. Heart rate is how many contractions per minute. So cardiac output is volume times by how many times the heart contracts. I've got those in the speaker notes, so you can have a look at those. Next, hormonal control of BP. You don't need to memorize too much of this, and you don't have to know the table yet. But a good thing to recognize would be to acknowledge that the angiotensin 2 has roles in the kidneys as well as the arteries to increase blood pressure. 2 other hormones that increase blood pressure are adrenaline, as it activates alpha and beta receptors, as well as ADH. So this is the antidiuretic is P, so against peeing hormone, also known as vasopressin. And so when you stop your body, when the body isn't peeing, then the water is retained in the body, and then the water increases the blood pressure. Okay, so now that we've talked about that, mean arterial pressure, we're going to move on to the lovely cardiac cycle. So I'm going to go through this and then talk through the diagram here on the next slide, and then go through the second half. So let's start with the green. Isovolumetric contraction. At this point, all of the valves in the heart are closed. So that's a question you could get. It's like, at what point in the cardiac cycle are all the valves closed? It's during isovolumetric contraction. So the main function is just the excitation of the muscles in the ventricle, also known as ventricular contraction. And this happens right after the ventricle has filled up with blood. So here the ventricle is full, it's being excited, and in early systole, right after the valves between the atria and the ventricles close, and before the semilunar valves open, we have this contraction of the ventricle. And here it requires a lot of energy, so it's when we have the highest oxygen consumption. Right after is going to be systolic ejection. So if systole is associated with the pumping motion, and ejection meaning expelling the blood, here blood is pumped from the ventricles into the circulation. And so that's the left ventricle going into the circulation and right ventricle going into the lungs. And this occurs between the opening and closing of the aortic valve. So in isovolumetric contraction, the semilunar valves, the aorta, let's use the left-hand side, left of the heart, for example. The aortic valve hasn't opened yet. It opens because of the pressure of the blood going from the left ventricle into the aorta. It opens the aortic valve. So here the valves are open. Ventricles contract, blood is ejected, and then as soon as blood leaves the ventricles, the volume in the ventricle decreases. Here are some numbers that if you want to, you can learn. And so that is going to be, so far we've covered contraction and ejection. This is the pressure in the left ventricle. 3, isovolumetric relaxation. So after the blood has left the left ventricle, it's going to relax. So this occurs between the aortic valve closing and the mitral valve opening. So at this point, all the valves are closed as well. So if you notice, isovolumetric contraction and isovolumetric relaxation is when all 4 valves close. It's also where we can see a dichrotic notch. We talked about this last week, if you can remember, right here. Osayumi talked to you about this, and it's the slight increase of aortic pressure in the early diastole that corresponds to the closure of the aortic valve. That's because as soon as the valve closes, there's still some blood being ejected from the left ventricle, hits against the aortic valve, and that's the pressure. The ventricles relax with no corresponding ventricular volume change until ventricular pressure is lower than arterial pressure. What this sentence means is the ventricles relax, but blood hasn't started to pour into the left ventricle or ventricles yet. And that's because at this point, the pressure in the ventricles is still greater than the pressure in the atria. So there's nothing that forces the valve, the atrioventricular valves, to open yet. Once the pressure in the ventricles are significantly lower, then the valve will open. This is also at the point where blood will flow into the coronary arteries to supply the heart. And so the coronary arteries fill with blood during diastole. And this is something you'll also learn in anatomy as well, the anatomy of how the arteries supply the heart, the actual heart, instead of just the circulation. So now that the ventricles are relaxed, we need to open the valves, the atrioventricular valves, and that's in ventricular filling. So ventricles fill with blood, and it happens in early diastole as soon as the mitral valve opens. Blood flows passively from the atria to the ventricles, and this is where most or a lot of the ventricular filling happens. And so if we use the same diagram, we can see the ejection finishes. We need to, there's a decrease in the pressure in the left ventricle. And then once after the relaxation, the valve, you can tell me which one, a valve will open, and then the filling will occur for the left ventricle. Some practice questions that you might like to have a go at is to identify which valves open and close when. And a really helpful hint is learn, for example, if you're going to get those diagrams with lots of different line graphs and stuff, I would use the left ventricle one because it tells us everything we need to know. As it also, and its relationship with the aortic pressure. So learn this will be quite good to learn, but also once you learn it, you won't have to memorize it because you'll understand it, and then you'll be able to go through the processes of figuring out, even if you get it in the exam. For example, let's do one together. Question, this one, what valve is closing at 3? So let's look at this. At 3, we've had ejection. Blood has left the ventricle to go into the aorta. So we don't want retrograde flow. We don't want blood to go from the aorta down to the ventricle again, so we need to close that valve. So 3 would be closing of the aortic valve, or the other semilunar, the pulmonary valve, I think. Okay, and so with my tips for this section, if you want for exam revision, learn when the valves are closing, both semilunar and both atrioventricular valves. Also remember mitral and tricuspid valves will close at the same time, open at the same time, and the semilunar valves open and close at the same time. 2, learn the opening and closing of the valves in reference to this diagram. The answers are here. And 3, know the names of the valves. Don't confuse between bicuspid and tricuspid. Know which side it's on, and then you should be fine for this topic in the exam.
Okay, so I'm going to be talking to you guys about the vascular endothelium now. Next slide. Okay, so start with some of the basics. This is not really too important to know, but I think it's already been covered as well. But the blood vessel layers go from tunica intima to tunica media to tunica adventitia, which is going from the innermost to the outermost. In between each of the layers, there's going to be a lamina that separates them. So you've got the internal elastic lamina and the external elastic lamina. Now, this isn't too important, but the internal elastic lamina has holes so that the endothelium can communicate with the smooth muscle underneath. And that will be really important for the function and action of nitrous oxide later on. But just some other details include that the tunica intima is a simple squamous epithelium, and tunica media is composed solely of smooth muscle, and the adventitia is collagen. So it goes like squamous endothelium, smooth muscle, and then collagen on the outside. Okay, so this is going to be the major focus of the lecture, I believe. So nitric oxide, and how it kind of works as a vasodilator. So it is an endothelial-derived releasing factor. So that's called an EDRF acronym. And basically what this is able to do is pass through the internal elastic lamina through those holes that I previously mentioned, and it acts to cause smooth muscle relaxation. Now, what this does is, if you're relaxing the vascular smooth muscle, then you're going to get dilation, and vasodilation will lead to decreased blood pressure, et cetera, right? So it's important, and we'll be talking about that coming up soon. Its production can be stimulated by acetylcholine, bradykinin, histamines, and also like 5-HT, which is serotonin, substance P. It's not really important, to know, I guess, what can cause nitric oxide, except maybe acetylcholine. But it's also really important to understand that shear stress, which is caused by really high blood pressure, can also cause an endogenous release of nitric oxide as well. So now next slide. Yeah, so these are the main functions of nitric oxide. Again, don't really need to focus on anything apart from the relaxation. I'll briefly talk about anti-proliferative in a bit, but it does have 5 main functions: the anti-thrombotic, anti-inflammatory, anti-apoptotic, anti-proliferative, and relaxation. So we've talked about relaxation, and yeah, that's fine. So nitric oxide synthesis and action. Again, I don't really know how much detail we're supposed to know this. I don't think I've ever been asked this in year 2, or I don't think I've seen stuff like this in year 1 exams, but just for your knowledge, so as calcium influx increases endothelial nitric oxide synthase levels. So that's called eNOS, which is nitric oxide synthase. Now, nitric oxide then breaks down L-arginine into L-citrulline, and nitric oxide is released as a byproduct. So that's kind of a confusing reaction, but basically the breakdown of L-arginine causes nitric oxide to be released, and it's usually released in 2 forms, either sodium nitroprusside or glycerol trinitrate, which are the main forms of nitric oxide. GTN should be somewhat familiar to you if you've done the pharm lectures, because it's used as a treatment for angina. Now, moving on, basically what nitric oxide does is it activates soluble guanylate cyclase and produces cyclic GMP. This is really semantics, but it decreases intramuscular calcium and leads to relaxation in the end, which is what's really important. Basically, you need to know L-arginine is broken down, nitric oxide is released as a byproduct, and this causes, in the vascular smooth muscle, a decrease of intracellular calcium, and that leads to relaxation because calcium is really important for the contraction of muscles. Now, there are some derivatives which prevent NO from succeeding. So this again, really low yield, but there's some inhibitors which are called LNMMA, but yeah, it's fine. Next slide. So this is kind of what's more important to understand because this comes up in exam questions. So you need to know the difference between vasodilators and vasoconstrictors. The vasodilatory factors include nitric oxide, prostacyclin, and EDHF, which is endothelium-derived hyperpolarizing factor. I already talked about nitric oxide. Prostacyclin, or PGI2, is non-lipid soluble and it acts at the surface receptors of smooth muscle. Basically what it does is it inhibits the COX pathway and inhibits platelet aggregation and also is used to slow down inflammation and vasodilation. Oh, sorry. It inhibits platelet aggregation, causes vasodilation, sorry. It makes the inflammation occur a bit better. So endothelium-derived hyperpolarizing factor, what does hyperpolarizing do? Well, think about depolarizing, that causes muscle to contract. Hyperpolarizing does the opposite. So if you have hyperpolarization, then you're going to have the relaxation of the muscle. Now, this is also kind of not that important, but it's shown to mainly only be used when nitric oxide and PGI2 production isn't really working. But it does cause smooth muscle relaxation, which is what's important. And looking at constricting factors now, you've got EDRF effects, which is relaxing, and EDCF, which is constricting. I just made a table for you to compare. But looking at constriction, vasoconstriction can lead to vascular remodeling, thrombosis, and inflammation as well. So some examples of constricting factors are endothelin, angiotensin, and thromboxane A2. Now, angiotensin is a part of that renin-angiotensin-aldosterone system that you might have seen in Caroline's slides about controlling blood pressure. But we'll talk, the main focus of this lecture is definitely endothelin. So next slide. So endothelin. So what is endothelin? Basically what happens here is nitric oxide inhibits the production of endothelin. So there's kind of a competitive reaction going on. So endothelin converting enzyme is what's used to convert big ET. I actually don't know what ET stands for. Oh no, endothelin 1, sorry. Big endothelin 1 into endothelin, like that's used. But nitric oxide inhibits this reaction. So that makes sense because nitric oxide serves to vasodilate and endothelin serves to vasoconstrict. Basically what happens is if there is a lack of nitric oxide or if there's just a surplus of endothelin converting enzyme, then what's going to happen is you're going to get endothelin 1 activating endothelin A, and this causes contraction. Okay? So basically it's the opposite. Everything that nitric oxide does, endothelin A does the opposite. So it causes vasoconstriction and stimulate proliferation, which I will briefly mention, even though this is the last of my slides. And it's also used as a treatment in pulmonary hypertension. So, sorry, ETA receptor antagonist is used in pulmonary hypertension because you want to cause vasodilation in that case. So just quickly about proliferation. In the endothelium, if you have a defect, then what's going to happen is you can have an excess of smooth muscle proliferation. And what that leads to is kind of a restriction of what's the word? Shortening or shrinking, that's it. Shrinking of the lumen of the blood vessels. And as a result, you're going to get hypertension. So hypertension is really highly linked to high levels of endothelin and also can be linked to low levels of nitric oxide. So it's really important to make sure that our body has that balance of nitric oxide to endothelin. Now, endothelial damage can also lead to what's called atherosclerosis, but I think that's already been talked about quite thoroughly. Basically, what you need to know is monocytes will infiltrate the endothelium when triglycerides are broken down, and they kind of ingest the triglycerides and turn into foam cells, which accumulate in the blood vessels, and that leads to angina eventually. So again, not too important, but definitely understanding the mechanism of endothelin and nitric oxide, very important for this section. But yeah, I think that's all.
Okay, hi guys. So just taking you through anti-arrhythmic agents for this week. So learning objectives are pretty simple. So looking at basic understandings of cardiac rhythm and different types of arrhythmias. And then we'll be looking at the different drug classes used to treat these arrhythmias, mainly the class 1 to 4 arrhythmic drugs, followed by 2 other ones that have been mentioned in your lectures. And we'll discuss the adverse effects and the mechanism of action for each of these. So firstly, what is arrhythmia? So simply put, it's an abnormal rhythm caused by issues with the conduction system of the heart. And we typically classify it based on the location, so whether it's in the atria or the ventricles, and then whether it's fast or slow, so tachycardic or bradycardic. There's a few different types. So first we have atrial or supraventricular. So this is in the atrium or above the ventricle. And the most common one here is AFib. So persistent, irregular rhythm. We've got supraventricular tachycardia, which is a rapid, regular heartbeat. Paroxysmal supraventricular tachycardia, which is essentially intermittent bouts of having a rapid, regular heartbeat. We have ventricular ectopic, so the ventricular arrhythmias, ventricular tachycardia, and then ventricular fibrillation. So a brief description of each of those are there as well. So drug classes, there's 4. We have NA channel blockers with their subclasses A, B, C. We have beta channel, so we have beta blockers, we have calcium channel blockers, and we have potassium channel blockers. And essentially each of these are acting on some part of the action potential. So with our sodium channel blockers, we have procanamide and quinidine class 1A, lignocaine for 1B, and flecainide for 1C. With 1A, they lengthen the action potential duration by prolonging the QRS interval. For 1B, we have a shortened action potential duration as the drug binds to the inside of voltage-gated sodium channels, inhibiting the influx of sodium, therefore preventing further depolarization. For 1C, the mechanism of action is that it decreases the slope of phase 0 during depolarization, and so this slows cardiac conduction. So some key takeaways are 1C you use in supraventricular tachycardia or paroxysmal atrial flutter or atrial fibrillation, whereas 1A you use mainly in atrial and ventricular arrhythmias, and then 1B post-AMI ventricular arrhythmia prevention. With our adverse effects, some key buzzwords for you guys are chronic lupus and torsades de pointes for class 1A. A further description of that can be found in these slide notes. For 1B, we've got a bunch of neurological side effects, with the key one here being there's a local anesthetic effect. And then 1C, cardiotoxicity is the key takeaway here, amongst other fairly common neurological and GI symptoms such as nausea and vomiting. Class 2 is our beta blockers. So we have atenolol and propranolol as our examples, atenolol being selective for B1 receptors and propranolol being non-selective. So we've got blocks B receptors, beta receptors in the heart to reduce heart rate, blood pressure, and cardiac contractility. It depresses the sinus node rate, slows conduction through the AV node, and prolongs atrial refractory periods. We have reduced sympathetic activation of the sinoatrial and atrioventricular nodes by noradrenaline, and then decreased depolarization in stage 4 to reduce the heart rate. Side effects, so we also have beta receptors on our lungs. So we can get bronchoconstriction, we can get decreased heart contractility, claudication, so pain in our calves, impotence and bradycardia. And we typically use these for AFib after a heart attack, prevention of ventricular fibrillation, hypertension is common, and an angina as well. So our third class is potassium channel blockers. We're looking at sotalol and amiodarone for our examples, and we use this for prevention of ventricular fibrillation as well. Sotalol is a beta blocker with class 3 effects, so you're going to have side effects similar to that of beta blockers. Amiodarone, the side effects are thyroid toxicity, lung and liver toxicity, and it may also aggravate arrhythmic effects as well. So you've got to monitor that carefully. In terms of mechanism of action, as the class suggests, we have blockage of the calcium channels, which block outward potassium current. This prolongs repolarization and increases the QT interval. The last channel is our calcium channel blockers, with verapamil being our example here. We use these in SVT, AFib, and prevention of, paroxysmal supraventricular tachycardia. Side effects are, so the key ones to note are heart block, spinal atrial node depression, and that happens if you combine it with a beta blocker. So be sure in an exam question to recognize that we shouldn't be combining calcium channel blockers and beta blockers because of these heart side effects. So we've got blockage of voltage-gated slow calcium channels, which prolongs repolarization at the AV node and the sinoatrial tissue. Two other drugs, we have digoxin. So its mechanism of action is that it blocks AV nodal conduction, slow ventricular rate in atrial fibrillation. So you use it in AFib, atrial flutter, heart failure. Side effects are nausea, vomiting, headaches, dizziness, so your common GI and neurological symptoms, bradycardia, and then it may also worsen arrhythmia as well. Adenosine depresses sinus node activity and slows conduction through the AV node, and also produces peripheral and coronary vasodilation. We use it in the acute treatment of supraventricular tachycardia, and one of the pros of this drug is that it has a very quick onset. Side effects, we have bradycardia, flushing, shortness of breath, chest pain, nausea, headache, and dizziness. So that wraps up anti-arrhythmic agents. I've made the table so that you guys can quickly see each of the mechanisms of action. So please refer to the tables. Otherwise, you can have a look at ePharm or AMH or your lecture notes for further resources. But as always, any questions, message me on Facebook.
Hi guys, it's Meg here. Sorry that I couldn't come to you live. Hopefully you can hear me okay. So I'm going to be going through some inotropic agents to begin with. The learning objectives for this lecture are to know the signs and causes of heart failure, to understand the pathophysiology of heart failure, list major drug classes used in the treatment of heart failure, describe the mechanisms of action of these drugs and their adverse effects, and have knowledge of ABD and inotrope. So ABD is just the acronym for the different classes of drugs we use for heart failure. Classification of heart failure, this isn't super high yield, but just class 1 means no symptom limitation of normal activity, class 2, dyspnea with physical activity, class 3, dyspnea with normal activity, and class 4, dyspnea at rest, that's just shortness of breath. To begin with, just discussing normal ventricular function, so how your heart should work under normal conditions. Cardiac output, that's how hard the heart is pumping blood around the body, that should increase with increased end diastolic pressure. So basically after, you should have covered this, I believe, in the physiology of the heart and how it pumps blood. But basically at the end of diastole, when the ventricles are full of blood, if that pressure or the volume of blood increases, then the heart should pump harder. Preload is what we call the stretch of ventricular muscle that is increased by blood volume and vasoconstriction. And if you have increased preload, it results in increased cardiac output. Afterload is resistance to ventricular emptying. So this is increased by peripheral vasoconstriction or anything from around the rest of the body that prevents the heart from pumping as hard. So this will cause decreased cardiac output. What is heart failure? So essentially, the easiest way to think of it is just that your heart can't pump hard enough. And this results in a backflow of blood back into systemic or pulmonary circulation, depending on which half of your heart is failing. Of course, it could also be both sides in congestive heart failure. So if the left side fails, the easiest way to think about this is where's the blood going to go. If the left ventricle can't pump hard enough to squeeze it out of the aorta, then it's going to go back into the left atrium. And then the left atrium is connected to the pulmonary vein. So it's going to flow back towards your lungs. So that's why the symptoms you'll see include congestion, so dyspnea and orthopnea. If it's the right side of your heart that fails, then backflow is through the SVC and the IVC. So then that returns it to systemic circulation or your body. So then you'll see symptoms like edema, raised JVP. Basically, if there's any symptom, just think about whether it's related to the lungs or the body, and then you can figure out if it's right-sided or left-sided heart failure. What causes heart failure? Basically anything. Hypertension, valve issues, ischemia, arrhythmias, cardiomyopathy, chronic heart disease, atherosclerosis, renal failure, diabetes, anything that affects how well your heart is working and how healthy your heart is can cause heart failure. Acute versus chronic heart failure. So acute heart failure is caused by an instantaneous event, such as an AMI, whereas chronic heart failure, that's the more common form that we actually see in the population. And that's something that happens progressively over a long period of time. That can be classed as either systolic or diastolic function. And currently we have a lot more treatment available for systolic heart failure. So you can see in this diagram or this picture on the bottom, on the left, you've got your normal heart. The middle, you've got your hypertrophied heart, and that's diastolic heart failure. And on the right, you've got dilated heart, and that's systolic. So first, for the diastolic heart failure, that's also called heart failure with preserved ejection fraction. So that means that the cardiac output is the same, but it just can't fill up as much during diastole, which you can kind of imagine if you look at the size of the ventricle, that's shrunk by the hypertrophied muscular wall. So there's not as much room there, but it's still going to, the ejection fraction is the same because it's still pumping out all of the blood that it can. Whereas in systolic heart failure, you have a reduced ejection fraction because the cardiac output's reduced. Those muscular walls that are so dilated can't squeeze as well anymore. Treatment principles. So firstly, lifestyle changes. As with pretty much any disease, they're always going to try and manage it without medication first. Then we have the two different kind of approaches to medication. We have decreasing the cardiac workload. So you've got three classes of drugs there, ones that inhibit angiotensin, diuretics, and beta blockers. So ABD, that's in the wrong order there. And then we've got another class of drugs which increase cardiac contractility. So those are positive inotropes. So first, beginning with angiotensin inhibition, we've got ACE inhibitors, which you should have already kind of heard about with high blood pressure. So as a refresher, angiotensin 2 causes vasoconstriction and increased blood pressure, among other effects. Those are the heart-related effects. So if we inhibit these using angiotensin converting enzyme inhibitors, they block the conversion of angiotensin 1 to angiotensin 2, thus lowering total peripheral resistance. So this makes it easier for the heart to pump because there's not as much pressure that's pumping against, if that makes sense. It also increases sodium and water excretion, which again lowers your blood pressure because the volume of the blood is lower. The examples of ACE inhibitors that you need to know are captopril, enalapril, and printopril, so any and pril. ACE inhibitors are used for hypertension, heart failure, and to preserve renal function and diabetes. And the side effects they cause are cough. It can cause hypertension if you give too much, and hyperkalemia. The most important one to remember is a cough. So dry cough, that's often a buzzword that comes up in exams, and that's as a result of increased bradykinin, and you can't use in pregnancy. We've also got angiotensin receptor blockers. So these kind of same principle, they're blocking the receptor for angiotensin instead of blocking the conversion of angiotensin 1 to 2. So these can also then reduce the total peripheral resistance and increase sodium and water excretion. The examples are losartan, irbesartan, or candesartan. They're the same indications as ACE inhibitors, but they're good for patients who can't tolerate the ACE inhibitors because of the dry cough. And they still may cause hypotension and hyperkalemia and shouldn't be used in pregnancy. Next, we've got diuretics. So these increase sodium and water excretion in the kidneys to decrease the blood volume and therefore blood pressure. They also reduce edema. We've got three different types of diuretics. Loop diuretics, which act on the loop of Henle, and the example for that one is furosemide. We've got thiazide diuretics, which act on the distal tubule. And the example of that is hydrochlorothiazide, easy to remember because it's in the name. And then we've got the potassium-sparing diuretics from the collecting tubules. And the example there is spironolactone. Because you actually haven't done an anatomy of the kidney yet, you don't really need to know the actual locations that these act on. Just remember that there's 3 different types and remember what their names are, but don't worry too much about the specifics. Just need to know that loop diuretics are more effective than thiazide diuretics, so they work better. They can both cause hypokalemia, so that's why they're sometimes used alongside potassium-sparing diuretics, which don't cause hypokalemia, so they balance each other out. Next, we've got beta blockers. So beta blockers decrease sympathetic stimulation of the heart, which kind of seems counterintuitive because we're worried about the heart not pumping hard enough, and now we're decreasing sympathetic stimulation, which is going to make it pump even less hard. But that can actually improve stable heart failure. It should only be used alongside other drugs when patients are stable, so not having an acute episode of heart failure, and you start low and go slow. So very low doses. There's 2 types. We've got non-selective, which block both beta-1 and 2 receptors. The example for that is propanolol or carvedilol. Then we've got the cardioselective, which only blocks the beta-1 receptors, atenolol or nebivolol. The side effects are cold extremities, it worsens asthma, so it shouldn't be used in asthmatics, and it can cause heart failure, so that's really dose dependent. Next, we've got the positive inotropes. So the first one is cardiac glycosides, and this is digoxin. So digoxin inhibits the sodium-potassium ATPase pump, which leads to increased myocardial contractility and thus an increased cardiac output. So it's just encouraging the heart to pump a bit harder. Unfortunately, these have limited clinical use. They should only be used if other drugs have already been tried. It can be used to treat atrial fibrillation or flutter, but it's got a lot of side effects. So arrhythmias, anorexia, nausea, diarrhea, visual disturbances, disorientation, hallucination. So as you can see, it's a pretty nasty drug. It's got a very long half-life, and the toxicity risk is increased by decreased potassium or increased calcium levels. So it shouldn't be used with loop or thiazide diuretics because if you remember, they can cause hypokalemia. Then we've got beta-1 agonists. So dobutamine increases cardiac contractility and therefore cardiac output. But again, it's got limited use because there's often downregulation of beta-1 receptors in heart failure. So there's not actually a lot of target for this drug, if that makes sense. So not the most effective. And here we've just got our stepwise therapy for heart failure. So sort of the order in which you would generally try these drug options. So firstly, a sodium-restricted diet and weight loss. That's your lifestyle modification. Then you would try a diuretic, so furosemide or hydrochlorothiazide, or an ACE inhibitor, so those are the ones ending in pril, or an angiotensin receptor blocker, so the ones ending in sartan. Next, you would combine drug classes or increase the dose of any of those. Next, you might add in digoxin, and then you would try a beta blocker or potassium-sparing diuretic if that didn't work. Next, we're moving on to lipid-lowering drugs. So learning objectives for this lecture: describe the processes involved in lipoprotein transport, describe the processes involved in the development of atherosclerosis and the subsequent risks, describe the non-pharmacological treatment of elevated lipid levels, describe the basic mechanism of action of lipid-lowering drugs, statins, fibrates, and cholesterol absorption inhibitors, and appreciate newer drug targets, so PCSK9. What are lipoproteins to begin with? So they were always a little bit confusing, but I think the main concept that you need to grasp and what will come up on exams is which ones are good and which ones are bad. So from biggest to smallest, we have chylomicrons. So these are triglycerides, and they are responsible for transporting dietary fat to muscle or adipose tissue. Then we've got very low density lipoproteins, which also are triglycerides. They cannot pass through blood vessels because they're too big to squeeze through the endothelium, and they're responsible for the transport of endogenous fat. Then we've got low density lipoproteins. These are cholesterol. They can pass through blood vessel walls and they're formed in muscle or adipose tissue. And we've got high density lipoproteins, also cholesterol. They can also pass through blood vessel walls and they remove excess cholesterol from cells. So HDLs, the high density ones, are good because they're going in and scooping up excess cholesterol. The rest of them are bad because they're essentially depositing cholesterol and fat. So hyperlipidemia. You can have it primary or secondary. So primary means that it can be due to excessive cholesterol or triglycerides. This can be caused by dietary excess, so eating or like consuming too many fats, or it can also be as a result of familial hypercholesterolemia. So this is a defect in the LDL receptor, which results in increased production of LDL. So that's caused by your genetics. Secondary hyperlipidemia can be caused by another disease, such as diabetes, alcoholism, liver disease, or certain medications you're taking. First class of drugs used are statins. So these inhibit HMG co-acetyl reductase, which prevents the conversion of acetyl-CoA into cholesterol. So this essentially means that you're producing less cholesterol. It increases the LDL plasma clearance, improves the endothelial function, and stabilizes plaque. So this is really good for atherosclerosis. The drug examples are simvastatin, pravastatin, and atorvastatin. So easy to remember because they have the ending statin. Side effects, they can disturb the GIT, cause insomnia or a rash. And statins are best for hypercholesterolemia, whereas the next class we're going to talk about are better for hypertriglyceridemia. So these are fibrates. They upregulate lipoprotein lipase, which decreases hepatic very low density lipoprotein production and increases hepatic LDL uptake. The examples are gemfibrozil or fenofibrate. So again, they've got fib in there. Side effects are pretty much the same, GIT disturbance, and they can't be used with liver disease because the liver is important for the metabolism. And these ones are better for treating hypertriglyceridemia. Next, we've got cholesterol absorption inhibition. So the first type of drugs are bile acid binding resins. So these bind to bile acids, which are your body's way of absorbing and breaking down cholesterol so that it can be like absorbed by the body. So if we inhibit these from doing their job, it means that there's less intracellular cholesterol in the hepatocyte. So the examples of drugs are cholesterol or cholestyramine. Side effects are GIT disturbances because now you've got all of this non-absorbed cholesterol and like fat passing through the GIT. The other one is ezetimibe. This inhibits cholesterol absorption across the intestinal wall, and it's generally better tolerated than resin, so less side effects, and you might use this in addition to a statin. Next, we've got nicotinic acid. So this is otherwise known as niacin or vitamin B3. This inhibits very low density lipoprotein secretion from the liver, although the exact mechanism is unclear, but essentially it results in lowered LDL levels. And finally, we've got fish oil. So omega-3 polyunsaturated fatty acids are also good for reducing triglycerides. And this is just consumed in fish, or it can be found as like supplements in tablets. Finally, we've got PCSK9 inhibition. So this is a new class of drugs that's currently, I think a lot of these are still in trial phases, but it's a new target. So PCSK9 is an enzyme which reduces LDL receptors, therefore reducing LDL clearance and increasing the plasma concentration of LDL. PCSK9 can be inhibited by antibodies, which are given as recurring subcutaneous injections. And the examples are evolocumab or alirocumab. So these ones are both monoclonal antibodies. Essentially, they're just would be attaching to the enzyme to inhibit it and prevent it from working. So that's everything from me. Thanks, guys.
So the rest of the topics will be on YouTube. Thank you very much for tuning in this week, and goodbye for the very last time.